to nephritic syndrome, so just kind of keep that in mind, and we're going to go through those. So y'all, I can't talk. Glomerular nephritis. That is the one I heard someone say from strep infection, viral infection. That's the one you want to keep in mind. That's inflammation of the glomerulus. So think of nephritis as inflammation. So these are the symptoms that you're going to see. We're going to have lower kidney output because we're not filtering, so we can actually see like BUN, creatinine, things like that going up. These are just symptomatic issues that your patients, clients may complain of with the proteinuria, hematuria. What's oliguria?
Decrease urine.
Yeah, and dysuria. Does everybody get that? Questions about? Okay. So this is a good little example of the nephrotic syndrome and the nephrotic syndrome. Nephrotic, think of the I, inflammation. Nephrotic, you're thinking of the O. You really want to focus on protein with nephrotic syndrome. So nephritic is inflammation. That's when you're going to have blood being spilled. Hematuria, it's going to look an easy way. Coca-Cola colored urine is a way a lot of the books actually describe it. Oliguria, Berger's disease, that's one of the primary causes of glomerular nephritis, plus you've got the strep infections and the viral infections. With nephrotic, you've got massive proteinuria, so you're spilling protein, but yet your protein in your blood count is going to actually be low, or your protein in the blood from the metabolic panel is going to be low. Peripheral edema, hyperlipidemia, hyperalbuminemia. These patients are going to be much more at risk for like DVTs, pulmonary emboli, things like that. So I made this little graph just to kind of get you all thinking, and I didn't put them where they're supposed to be so that y'all would have it so that you can kind of go back to study it. Where would the increased risk of PE and DVT go? With
Nephrotic.
Perfect. And edema?
Nephrotic.
Yes?
For the PE and DVT, why would it be nephrotic?
So with the PE and the DVT, I actually made myself a note for that.
What do you think goes to hyperlipidemia?
Yep. It's in a hypercoagulable state. So high protein levels in the urine, low protein levels in the blood, they cause the low albumin. That's when you're going to see the high cholesterol, high lipids, things like that. Let's see. Yeah. Okay. So our low serum, high protein is going to go which? And Coke-colored urine?
Nephrotic.
Elevated cholesterol? And the albumin? Which one is after a strep infection? And which one would have casts in the urine, pus, cellular? Why? And think of that one as you've got inflammation, you've got infection, things like that. After acute viral? So what do you think would be some viral infections that might cause? We got strep already. What is some others? Epstein-Barr is one. What is Epstein-Barr from? Mono.
Hepatitis B, varicella zoster.
Autoimmune disease, that's both. So, and hypertension is with the nephrotic syndrome. So, it's just kind of, I say when you're studying these two, this is a really good scenario where you want to make like a Venn diagram. Did you just take a picture of that?
Is that on there?
You can take a picture of it, because I didn't separate them out on your guys's, so feel free. But this is a real good one for like a Venn diagram. Yeah.
So you said that with nephrotic, the causes are due to just autoimmune disease, is that the only one?
So that's just like when they're spilling the protein and things. So different ones can cause nephrotic syndrome. So, but it can, it's just sometimes nephrotic syndrome is with the autoimmunes, and then it could just be based off of, your elevated cholesterol, things like that that may attack the kidneys. Any other questions? Everybody get a picture of it? Okay. So when we're talking about health promotion, our at-risk groups, we've got our diabetes, hypertension, immobility, immunocompromised. That's going to be where that education comes in to kind of help teach them about that. Infection prevention, education do's and don'ts. What would be some education that we would want to do? What about someone with, say somebody's been in the hospital and they've had a Foley, what's kind of education that we can do when that Foley's been discontinued? Or before the Foley's discontinued. Say they've had a renal calculi, which is an obstruction we'll go into in a little bit. What would be some education that we would do post?
So after they take it.
Kind of like think bladder retraining, things like that. So how would they do bladder retraining at home?
Urinating at the same time every time.
Same time, timed, like you would do timed every 2 hours. I always tell people just start going to the bathroom every 2 hours to kind of retrain that bladder. Because what happens when we have a catheter in? Say again. What'd you say?
You just urinate automatically.
Right. So our muscles get lax, right? So we want to retrain those muscles. Has anybody ever heard of Kegel exercises? Yep. So, having them do Kegel exercises, bladder retraining. Women who have babies often have to do Kegel exercises after having babies, things like that. So kind of teaching them those types of things. The pelvic floor exercise. They actually do one that's called biofeedback electrical stimulation, where they actually insert little electrodes up there that kind of help stimulate the muscle contractions and stuff. They can go in, they can have that done. They actually make those little devices to go home with as well. So biofeedback, electrical stim, Kegel exercises. Kegel's what you're going to hear most of the time. So urinary incontinence is inevitable and is not treatable.
False.
Right, because we just talked about all the things that we can do to help. So now we're going to talk about our obstructive uropathies and bladder dysfunctions. So we've got the renal calculi, which we've kind of talked about a little bit, urinary incontinence and retention, urinary diversions, BPH, and prostatitis. So I picked this one just to start. Prostatitis, what is that? Yeah. Itis is inflammation of everything. So, they can have the fever, the chills, nausea, vomiting, body aches, all of that. They can have a UTI as well. So, they may have bacteria, cloudy, bloody urine, things like that. So it's just, like I said, it can be related to a UTI, but it can also be related to BPH, the benign prostatic hypertrophy, to where there's an obstruction, something not allowing that urine to flow. So it's pretty cut and dry. So let's look at urinary tract calculi. So, and we all know that's like a renal stone, right? Anybody ever had a kidney stone? You don't want one. Mr. Lyons, he's undergone treatment in the past for kidney stones. He's had them 3 times in the last year. Poor man. He calls his provider. He's got acute, excruciating, colicky pain. It's radiating down towards his thigh, towards his genitalia. It started last night, progressively worse. He has the urge to void, but little output. Urine is blood tinged. Due to the pain, he's not taken any food or fluids in 24 hours. So, typical scenario, what do we think? He's got an obstruction somewhere, right? Where would we think he had an obstruction based off of his pain?
Urinary?
That's
Yeah.
what I was saying.
Yep. So, and then what are some other things that are concerning with this?
Blood tinge urine.
Blood tinge urine. What else? Somebody up there said something. What did you say?
Not enough fluids.
Not enough fluids. That makes him at risk for what? UTI, dehydration, hypovolemia, all of those types of things. Obviously, severe pain, that's an issue, because of severe pain, you will actually, my husband had one of these, and he woke me up at like 2 o'clock in the morning, and he was like laying in the living room floor, rolling on the floor. And so he's like, I'm dying. That's literally what he told me, is he said, I think I'm dying today. I'm like, you're not dying, I think you have a kidney stone. And that made him even more mad. So I gave him ibuprofen, he had some hydrocodone, and I'm like, well, the only way we're gonna know is if we go to the hospital and have them do a picture. So that's what we did, and I had already medicated him. By the time we got there, he already felt better, and the doctor was like, yeah, kidney stone. So then he got even more mad at me. So, you know, but it's the pain, you know, you definitely think ureteral area, no urine output. So what is that gonna make him at risk for?
Overload.
Acute kidney injury, right? Because if he's not passing urine, we're not filtering anything, so we could have lots of abnormalities in our metabolic panel and things like that. So he undergoes lithotripsy. What is that?
They go into like break down the stool.
Right. They go in to break up the stone. They analyze the stone. So it is good when they are able to find out what type of stone, because that's when we can find out how we can help to prevent them moving forward, whether it's from uric acid, whether it's from calcium, things like that. So these are the type of orders that you would see. So he gets these orders. Now, why would we give him morphine? Pain. But what else does morphine do? It kind of dilates out, right? So it helps to dilate vessels out so that things can pass through. So that could be one thing as well, plus the pain, because if pain goes uncontrolled, it can, you know, it can progress to where he could pass out, seizures, things like that, just based off of pain alone. And ibuprofen, we're going to give him that. That works as an anti-inflammatory, which will allow the stones to pass since they've been broken up. And then normal saline. What's normal saline going to do?
Help flush it.
We're going to flush everything through so that he's able to pass them, because he's not been able to take the fluids in, and we already anticipate that he's probably dehydrated. We know when they're dehydrated, his urine osmolality, is that going to be low or high? Going to be more concentrated. So when we're dehydrated, our urine is going to be much more concentrated. So yeah. So let's see. What kind of education are we going to talk? We know it's a calcium stone.
So prevent like excess calcium intake.
So actually, you know, current practice guidelines say that we're actually not going to limit the calcium. We just might want to limit, you know, certain things that are in our diet, because when we limit our calcium, that is going to make all of us at increased risk of like osteoporosis. So, you know, they used to say limit your calcium, but then they have shown through research that that's not best practice. So, you know, kind of keep that in mind. What are some foods that we would want to have them avoid? Red meats, yep. So if we have a calcium, let's see, we've got calcium stones. So we talked about we're not going to lower our calcium level, but oxalate foods, so like spinach, chocolate, peanuts, Swiss chard, what that is. And then we're going to avoid like caffeinated drinks, Cokes, teas, things like that, because those make people more at risk as well. So those are just some kinds of things. Now, if you have someone that has like gout, if they have gout, what are they high in? Uric acid. So we want to kind of make sure that they're able to control that uric acid too. What are some foods that are high?
Purine.
Hmm?
Purine.
What are purine foods? Somebody said one. Shellfish, anchovies, asparagus, mushrooms, organ meats. So, you know, if you've got someone with gout, those are some things that would be important to know. And these are all in your book. This case scenario I actually just pulled from your book as well. So, and it's got diet information as well. Urolithiasis and nephrolithiasis, you'll hear those terms, and that is just other terms for kidney stones. So just kind of keep that in mind as well. Our high-risk patients for renal calculi, that's going to be like your polycystic kidney disease patients. That's going to be if you have chronic strictures from inflammatory bowel disease. Maybe they have ileostomies or they've had to have bowel resections, things like that. That's going to make them more at risk for those strictures. Excessive antacid use, things like that. High doses of aspirin, that's another one that I wasn't familiar with, but that's another, you get someone that takes lots of aspirin that can definitely contribute to renal calculi as well. So my brother deals with these probably about every 2 to 3 months. And so if someone's having recurrent renal calculi, what does that make them at risk for? Scarring, right? Scarring is going to lead to what type of pyelonephritis? Chronic. So they could be at high risk for chronic pyelonephritis because they've got scarring due to frequent stones, things like that. So just kind of putting it all together. Any questions about renal calculi? You'll see these a lot. You know, sometimes if the stone is in there, they may break the stone up. Then you may actually see them go in for procedures where they actually have stents placed. And then they keep those stents in place while they're getting the fluids. They may go home with the stent as well. A lot of times the stent will have a string attached to it, and they will go back into the urology office, and that string will be pulled out and that stent will be removed. So that gives the time for all of those fragments of stones to be passed. So a lot of times these patients, once they're stabilized in the hospital, they will go home on some oral antibiotics until they follow up. Sometimes they will go home with a Foley, sometimes they won't. It just depends on their ability to void or based off what the urologist sees when he goes in to do the lithotripsy. So if they go home with Foleys, we want to make sure we're doing education as far as Foley care, things like that to help prevent infection. They may have them do bladder training from the office to decide things like that. If you get a urology patient, you always want to make sure that you don't remove the Foley if there's an order for it to stay, because you're going to have a very angry physician. So you always want to check your orders for those types of things. And the hospital has a lot of initiatives because there's what we call hospital acquired infections, and Foley catheters is one of the initiatives that they have. So they will try to remove a Foley as soon as possible on these patients because of the risk for developing UTIs, things like that. Because if the patient develops a UTI while they're in the hospital's responsible for that bill. So they can't bill Medicare for something that a patient acquired while they were in the hospital. So that's, another, while you will see Foleys, falls, if someone breaks a bone or something while they're in the hospital's going to be responsible. So just so that you know why you see those things, post surgeries, they usually want to get those Foleys out by the next day. So urinary incontinence, there's all these different kinds. We all know what stress incontinence is, urge incontinence, functional, latrogenic, I didn't even know what that one was. That's like the involuntary loss of urine from medical conditions, maybe because of medications or things. And I guess clonidine is one that can cause latrogenic incontinence. So just kind of keep in mind. Mixed is obviously a combination of all of them. We talked about bladder retraining, nerve stem, all of those types of things. So causes of urinary retention, we talked about, surgeries, diabetes, enlarged prostates, tumors, infections, stones, trauma. When we start talking about devices for like urinary diversion devices, that's usually because of trauma. Pregnancy, neurological disorders, medications, enlarged prostate, that's pretty self-explanatory as to why it would cause retention. Same with surgery as well. Pregnancy, just because of where the baby's sitting, you could be obstructing. And then we talked about neurological. So we talked about a lot of these already. So when we talk about continent urinary diversions, this is where we have to have a different mean for a patient to urinate, right? So in this picture right here, this patient doesn't have a bladder. Like I said, the majority of time, this is going to be due to a trauma. So you have someone comes in that's had trauma to their bladder based off of a motor vehicle accident, a stabbing, assault, things like that. That's when you might see types of things like that. Neurogenic bladder, that's another one that you're going to hear of, and that's going to be caused from like your spinal cord injuries. That's a lot of times when you're going to see your suprapubic catheters and things like that. Can be from complications of diabetes, with neuropathy, things like that. So this is what the Indian pouch looks like, and they actually take tissues from the intestines to make this pouch with a stoma. And so if a patient has an Indian pouch, you actually have to teach them how to straight cath themselves, because they will straight cath themselves through the stoma. This orthotopic neobladder, that's when they have actually built a new bladder for the patient. So that's also taken from part of the intestines to where they will make a new bladder. These are urinary diversions. The ileoconduit, that's the primary one that we will see. That's when you'll have the ileostomy. So, not ileostomy, I'm sorry, urostomy. Ileostomy is when it comes from the small intestines. So this is urostomy. And then you've got nephrostomy tubes as well. Sometimes you get patients that have really bad strictures in the ureter, so they will go in and have nephrostomy tubes placed, or they may have infection, or if they've had like a kidney tumor, cancer, things like that, that's when you're going to see these types of nephrostomy tubes. They will be in permanently, or they could be in temporarily. So BPH, this is a big one that you will see as well. You can see where you've got the stricture and that urine is not able to flow right through here. So, sometimes they will go in and dilate that up. What is the procedure that will often come into the hospital that you will see? Anybody know? Surgery? They go in with the urologist. They go in, and what they do is they shave off sides of the prostate gland to help open it up, and then they will you'll see these people connected to a irrigation system. Urine will be very bloody initially. Have you heard of a TURP? Nobody? Okay. So that's kind of where they go in. I don't even know if I wrote. It's a transurethral resection of the prostate. But you'll just hear it called as TURP. They come out of surgery. They're on what we call a Murphy drip. And so it will be probably about 3 or 4 liter bag of saline, and that's going to be continuously running in to where the surgery is, and then it's going to be coming out. So it's like a Y set. So you've got fluids running in and fluids coming out, and that's to help prevent clotting. So they will still clot, and so as you're watching that, they will turn that down. It's not hooked to a pump or anything. You've just got your little dial that you're going to open up to close, and they may say leave it open full, and then the urologist is going to have you decrease that. Once the urine is pink tinged, then they will take that out. Sometimes they'll go home with a Foley after a TURP. But they are at very high risk for clotting just because of the trauma that they've done, because they literally go in and shave off these sides of the prostate so that they can open that up. Has anybody seen those?
They shave it from the outside.
No, they go inside. So it's like a surgical procedure. They go up through the urethra in there. It's all laparoscopic. And they're gonna shave off part of the prostate on each side to where it opens it up. Does that make sense? Yeah. So, like I said, bleeding is always a risk, so that's why they will continuously run fluids in, and then those fluids are continuously coming out. So you always wanna make sure your eyes and nose are equaling out. And sometimes you have to do like flushes with it too. If it gets clogged, you'll have to do flushes and stuff with it too. The more you see it, the more.
What is that procedure called?
It's called a TURP, which stands for transurethral resection of the prostate. And it's just where they excise the excess prostate tissue. Any questions about that? None? Post-op complications, so you always want to worry about infection. What are some things that we would do post-op? Always. So, and this is just something that, I stress to all of you as you guys go out in clinicals. You've got the time with your patients. You really want to make sure they're doing. Anybody having any kind of procedure is at risk for complications. We're wanting to make sure that they're using their incidence spirometer, coughing and deep breathing. Nobody's going to tell you to do it. Nobody's going to make you do it, but it can really impact your patients. So, just make sure that you guys are doing those things. If they're in bed, we've had patients that are in bed, they may be sleepy. We gotta wake them up, we gotta get them up, we gotta get them going, because that's gonna be what helps improve patient outcomes, and that's gonna be what's best for the patient. So, a lot of things about nursing that we do, nobody tells us to do. If you have little confused people, they still, you can still sit there with them, and if they can't use the incidence spirometer, you can just sit there and breathe with them and make them take big deep breaths and make them cough and do things like that. So there's still things that we can do if our patients don't understand the normal ways of doing things. So just kind of keep those things in mind as well, because moving forward, like I said, you're gonna get more responsibility and you're gonna start doing more stuff. You can't forget the basic things, because those are the things that really impact. I always tell my clinical group, anybody can learn to put an IV in, anybody can learn to put a Foley in, but not anybody will take the time to really work with their patients to help improve their outcomes, talk to them about their disease processes to really try to improve, to make them a healthier lifestyle for them. All right, you guys, we got done early. Does anybody have questions?